Mm. No. I think I got that.
Hey, I can't hear you. I can't hear you. Can you hear me? Can you hear me? Okay, I cannot hear you.
All right.
Okay, I can hear you.
You can hear me now. Okay.
Yes, ma'am.
Okay, good. All righty. And I'm going to maximize that. Okay. Okay, I think we're good now.
I think we are too.
Can you? Oh, thank you so much. Okay, good.
Thank
Carolyn,
y'all.
I can hear you now. All this lovely technology everybody's playing with today. Okay, we're good. All right. See, there we go. We work. We work. Always something.
And to let y'all really know, it was me that started out. I couldn't even get into the session, and I had to call Kathy.
Oh, well, it's all good.
It is. We're here now.
Yeah, thanks, Carolyn. Of course, now they have to start working outside, so the dog starts barking. Oh.
Mine's asleep, so maybe he'll stay that way.
Well, have a couple of our consultants on. Maybe some of the others are taking a quick break between the last presentation and this one. I think
Maybe
most
so.
of them ended at 2:30.
I think so. Hope everybody's doing good today. It's beautiful outside here today.
Hmm. Ooh, what was that?
It was me. It was me. My finger hit my mic. I'm
Don't
sorry. It was terrible.
do that anymore.
Sorry. I'll keep my hands away from my face.
Nice breeze blowing.
It's beautiful here. It's absolutely gorgeous.
All right, where is everybody? We have our ever faithful consultants on here, but where's this? Where's FAMI people? Carolyn, did you watch Vaughn's presentation? She might not be able to hear me. Good afternoon. I'm going to give it a few minutes here to let some other folks join us. We'll just wait a few more minutes. And then we'll get started. Oh, now they're coming on. Or not. Okay, I don't know who else is on. If I should be able to see everybody that's on. If you're here, if you would just let us know in the chat box, that would be great. We would appreciate it. This afternoon, oh, somebody talking about pets. Well, mine are all low to the ground, so you won't see them, but you might hear them, unfortunately. So that's funny.
Mine is asleep right now, so we're going to hope that he stays that way.
Right. Pets and children, right? So first of all, we would like to thank the FAMI section of NCPHA for inviting us to present again this year. Brooke and I will be presenting today, and our colleagues, Becky Webb will present tomorrow, and Brooke will be back to present again with her. So we're looking forward to that. Today, our topic is a guide to successful coding and billing. And before I start, I should have mentioned, if you have questions or comments, please put them in the chat box. We have designated time built into the presentation to address those, and we will definitely stop and take time to answer any questions or comment about things that might be said in the comment box. So thank you so much about that. So our topic, a guide to successful coding and billing. Make note of the title of this presentation. You can code and bill all day long, but if you don't do it correctly, it creates more work for everyone. We want to provide you with some tips that will help this entire process from visit to reimbursement run smoothly and successfully. Okay, why do we bill for services? Because we need revenue, right? So we get revenue, but we want to increase your revenue. And what are ways that we can do this? Well, there's a list of things on the screen in this particular slide that you can do. Public health is typically perceived as a free service, right? We're getting better. We've gotten better. In the 20 years I have been in public health, 20 plus years, that perception has improved, and not everybody expects all of our public health services to be free anymore. So that's definitely a good thing, but we still have a long way to go. So client education is definitely one of the things that's very important in this arena, making sure that your clients understand that they do have an obligation to pay. All staff need to share the same message. Services are not free. Your agency cannot operate without fees and revenue. Change the way you greet patients at the checkout window. How was your visit today? Ask them. Your total today is blank, and expect them to offer to pay or say, how would you like to pay today? Not, would you like to pay today? How would you like to pay today? Would that be cash, credit, debit, whatever? Whatever you accept. Hi, Andrea. Thank you for joining us.
I apologize. Why I was on the session from for tomorrow.
Oh, well, you were jumping the gun, weren't you?
Yes, ma'am.
Well, welcome. Thank you. So like that, change the way you approach your clients. If a client is unable to pay for their full balance on the date of service, offer a payment plan, develop a payment plan for them, and set the expectation that you are supposed to pay this bill according to this payment plan that they have signed and agreed to. You may have to have a tickler to remind them of that. You always need to remind your individual clients every time they come in if they have a balance outstanding. Be sure you mention it to them and talk to them about the balance and how you can get that balance reduced and paid off for them. So, the consolidated agreement states that you must make every reasonable effort to collect your cost in providing services. So how are we going to do that? There's several ways. We bill Medicaid, which is our primary pay source in public health, right? And then we also can bill third-party payers. How many in the audience are actually credentialed? Are you credentialed with as many third-party insurance companies as you can be? You want to make sure that you are not restricting your income limits based on the fact that you're not engaged with the third-party payers. Some of them are difficult to get credentialed with, but if you don't try, it's not going to happen at all. Okay, so make sure that you reach out to those insurance companies. I've got a lot of my counties recently reaching out and asking me about that. There's several ways you can do that. We're always happy to help. If anybody has questions, make sure you contact your admin consultant. We'll be glad to help you walk through that process. We want to make sure that you obtain all the revenue that you possibly can. Whoops. Hang on, sorry, lost you. Oh dear me.
We can still hear you and see you.
Okay, I had my, yeah, there we go. I got to get involved in the way I'm looking at two different things, and I have to move the slides on another. My apologies, I'm so sorry. So when we're billing third party, you always remember that you bill your third party payers at a 100% of the charge for the service today. So patient comes in, they've got Blue Cross and Blue Shield, their bill is $100, you charge $100. Now, you may accept a lower amount because you might be in network with Blue Cross and Blue Shield. So you accept from them a standard rate that you all have negotiated for reimbursement. Same goes with Medicaid. We're going to bill Medicaid our fee, but they're going to pay us what they're going to pay us. And that's just the way that works. So, and then again, self-pay clients we know are based on income and family size, and you want to bill them based on sliding fee scale. Where do they fall in the sliding fee scale? So, some general billing information I want to share is this. We've got a couple slides that talk about a few things. There are multiple forms of payment that you may accept, and I hope that you are using all of the above. You can do cash, obviously, cash and check, major credit cards, debit cards. Many of you are using debit cards now. Of course, all the insurance payers use debt set-off clearinghouse for those debts that are outstanding. That's considered a source of revenue, and we're going to talk about that a little bit later in the presentation. But you want to be sure that you are able to accept all the possible forms of payment that you can. That way you're not limiting yourself to what the client may have to offer. How many times have you been, if any of you have done the checkout process, you've been at the desk and you say, will that be, you know, cash, check, or credit card? Well, I don't have my card, or I don't have any money. Oh, well, there's an ATM downstairs if you want to go ahead and use that. Try to tap into all those possible resources, and that will help definitely increase your revenue. So here are just a few other pieces. Medicaid is always the payer of last resort. Remember, we have to bill everybody else except Medicaid. They're always the payer of last resort, unless, of course, it's a self-pay client, okay? So you definitely have to remember that. They won't pay it, they'll kick it back. We have regular soccer matches going back and forth between Medicare and Medicaid because Medicare said, oh, you have to bill Medicaid, and Medicaid said, no, you have to bill Medicare, and nobody wants to accept responsibility. So what do we do with the ball, right? That's when we bounce it off our heads and just try to figure out what to do next. It's always a challenge with those two payers. So anyway, with Medicaid billing, remember when you bill Medicaid, you can bill for certain services that aren't covered by Medicaid. However, you may have to make sure, I'm sorry, I'm tripping over my words for some reason today. You have to make sure that you inform the client ahead of time that Medicaid won't pay for it, and they are expected to pay the bill based on sliding fee scale, okay? If a client comes in, they say they have Medicaid, but for some reason you're not able to verify that, all systems are down, right? We're at ground zero. We're working off of paper. We've had to do that before. If you're unable to do that, then you can bill at 100% until you can verify the Medicaid, and then you can switch it over to Medicaid, okay? If you're able to do that. If not, you bill the patient where they're at based on their income. Also, if the client presents for services that are billable to insurance, You want to make sure that you obtain all the information that you need in order to build that claim. That typically is fill in the blanks in your third party or your EMR. You need the name and the identification number, group number, all that kind of stuff. So make sure you get that on the front end rather than wait until the claim comes back to you, because what does that do? That delays your income. It adds more work. Like I said at the beginning, adds more work for everybody if you have to submit that claim twice, and we don't want to do that. We want to make it as smooth and seamless as possible. So, collecting copays and applying sliding fee scales. You'll have a more in-depth, very detailed presentation about this tomorrow with Becky and Brooke, but I just wanted to hit some high spots today regarding sliding fee scales and just talk a little bit about it, because it is part of coding and billing and successful billing practices. So 5 steps for collecting copays and applying the sliding fee scale. First one is you need to know what the patient's income is, right? And how many people they have in the household. We've talked about this on multiple occasions in other trainings. What's the economic unit? It's based on the economic unit, which is a formula that looks at how many people in the household and how much money is brought in and what the relationship of goods and services is to that revenue. And then that's who you use to determine the actual sliding fee scale placement. So make sure you check into the patient's insurance eligibility. One good thing that you could do is to do this before the patient comes in. Have kind of a pre-visit. Look for insurance information, get their eligibility information, make sure they've got Medicaid, do all that stuff ahead of time. That way you're not fumbling and waiting and wasting time and spending time on the day of the visit, and you can get moving along. You have it already. I know it's not always easy to do that. Sometimes it's a little difficult, but if you could do it up front ahead of time, go ahead and get that done. The next 2 points are related to family planning specifically. And this came into play, I don't know, 4 or 5 years ago, I think, something like that, where Title 10 says if a client has insurance and their copay is less than they would pay on sliding fee scale, then they would pay the copay and not the sliding fee scale amount. However, if the copay is more than they would pay based on sliding fee scale, they pay the sliding fee scale amount. So let's just break that down for a second. So a patient comes in, we'll use that same $100 because it's easy to do math with. So there's a $100 bill in services. They have a $25 copay for their insurance. However, they fall out at 20% on sliding fee scale. So they're going to pay that $20 instead of that $25 in the copay area. All right, you're still going to bill the insurance, but the patient's responsibility is going to be the lesser of those 2 amounts. I think we've talked about this in just about every training we do, but it's always good as a refresher. We don't want to make any boo-boos where it comes to Title 10. So they've come in and had their services, and we've billed everybody, and now we've got patient outstanding accounts. How do we manage those outstanding accounts receivables that we always seem to have hanging around, right? We'll have them for all of our insurance companies. We have to figure out what to do with them. You won't have it for Medicaid. You always know that, automatically your systems should be set to write off any balances after Medicaid pays for a service, unless it's a denied service, and then you want to work that claim. And then sliding fee scale, if a patient accrues a lot of money in their accounts, you want to make sure that you're working those accounts and looking for all options and all ways that you can collect that revenue. Okay. So how do we find out what those outstanding accounts are? Our aged accounts receivable report is probably the best report that you can run in the whole agency as far as billing is concerned. It's going to show you all those details. It's going to show you how much you have, 30, 60, 90, Hopefully there's nothing at 120 and more other than the self-pay, which we know there's going to be. But you want to make sure that you're keeping those payments within that 90-day period so that you're not just spinning your wheels and having a lot of outstanding dollars sitting out there. If there's money out there that needs to be worked, you need to make sure that your staff is getting in there and looking at these accounts on a regular basis and going in and working them that's just what we say in the business. We're working those accounts, just like we work the RAs, and Brooke's going to talk about that a little bit later. But it's important to make sure that you're not leaving money on the table. You want to make sure you get every dime in that you possibly can. If you can't get Medicaid payment or insurance payment in a timely fashion, again, it just makes more work for everybody. You have to remember we receive less and less money from the state and federal government due to the economy of where we are at this date and time. So it's the responsibility of the health department to make sure that you can get in all the other dollars that you possibly need and possibly can to support the services that you want and need to provide to your communities. And that's not counting anything that you would receive from your local government, but you still have to bring in a little bit. You know, they expect you to bring in something to the table. Another tool that you can use in your aged accounts and looking at your aged accounts is the bad debt write-off. So this is when you've exhausted all possible efforts to bring in money, and you've got a policy that says that you leave the debt out there for 12 months, and then it is reviewed and submitted to your health director to be considered for a bad debt write-off. So if that happens, this report will show, basically it can show an account number and just the amount of money to be written off. And somebody has already ensured that it meets the curriculum or criteria of a bad debt. So goes to the health director, goes to the board of health, goes to the county commissioners, then we write that money off. Okay, we adjust that money off. So typically that's usually the way it stays. It's gone. We don't get it back. Every once in a while, you'll have somebody come in and they'll want to make a payment on their account. Don't tell them the debt's been written off. That's a no-no. We don't want to do that. We never want them to know that we wrote their debt off. However, what you can do is you can take the amount of money that they want to pay, put it back on the account, post the payment, and then you're done. You don't have to worry about having any other money hanging out there from a bad debt. We don't recommend that you leave it out there, that you put or reinstate the whole debt. Just put back the amount they want to pay, post that payment, and move on. Because what'll happen is if you reinstate the whole thing, it's going to just show up on your bad debt write-off report again next year. So that's pretty consistently the way things happen. So we don't want to add, again, extra work. Other things that could happen is a client may file for bankruptcy. There's a couple different kinds of bankruptcies. You will receive notification from the courts if there is a bankruptcy application. If they've approved that application, make sure that you are reading that bankruptcy letter correctly and looking out for instructions on your behalf. Sometimes it may be that you have to file a bill with the bankruptcy court, and it can be included in a bulk settlement amount, or sometimes the courts will just write it off based on what the circumstances are, and you have to write that off as well. That can never be put back on the bill. You can't bill the patient. It has to stay gone. So be sure you're reading those instructions very carefully to make sure you're doing the proper thing with that account. Debt set-off clearinghouse. This has got to be the best thing that since sliced bread that happened to the local health department world. In the past, the tax department was able to utilize the North Carolina Debt Set-Off Clearinghouse to collect debts. But a number of years back, they added in the local health departments, and EMS were able to contribute or put in a report, file a report, and if an individual had a tax return, state tax return, and they added lottery winnings over $600 that you were able to attach to that debt and get paid. So if you have a bunch of people that have submitted a bunch of sections within the county, say you've got tax, you've got health, and you've got EMS, used to be the tax got the first piece of the pie. Now it's whoever gets their money, their request in there first. So be sure that you're doing the debt set off reports and submitting debt to the clearinghouse several times a year. Don't just wait until the end of the calendar year. First of all, it's a tremendous amount of work. You've got to send letters out to the client, letting them know that you're considering sending it to the clearinghouse, that they may not get a tax return or they may only get a partial return. And then after that 30 days, you can submit it if you have not heard back from them. Okay. Otherwise, you may not get it if you don't follow the rules. Okay. So far, I checked the statistics today on the Debt Set Off Clearinghouse website. Now, this is overall, this is all departments, county governments, and municipalities together. But since Debt Set Off was initiated in 2002 in our state, they have collected over $343 million. Now, obviously, not all of that is health department money. We'd be rolling in it, wouldn't we? But that is a big chunk of change for them to have been able to collect over this time on behalf of county government. Just in 2020 so far, they have collected $20 million, over $20 million in outstanding debt for either tax, health, or EMS. So it is definitely worth the effort. If your county agency is not currently signed up to use the Debt Set Off Clearinghouse, we encourage you to make sure that you do. It does require having a local policy in place, but that's an easy thing to do. And we've got sample policies out on the local health department DPH website. So we make it really easy for you. Just cut and paste, plug in your name. Okay. Just a few things to let you know what is required for debt submission. These requirements must be met. And if they're not met, you have to be very careful because you may have to refund money. We don't want to do that. So you've got to have a Social Security number or an ITIN, which is an individual tax identification number. If someone doesn't have a social, ask them if they've got an ITIN, and hopefully they will provide it to you. The debt has to be at least 90 days old. That means 60 days in your outstanding accounts receivable, plus that 30 days for you to send a letter and get a response back from the client. It's only that you have to demonstrate the effort to send the letter. If it comes back to you, return to sender, it's fine. You don't have to worry about that. You just have to demonstrate that you attempted to contact the individual about the debt. The amount has to be at least $50 worth. Again, you must give proper notice, and you must give them the right of appeal, which is in the letter that you send out to them. And again, there is a $15 fee associated that actually gets charged to the individual client once you send them to Debt Set Off. So it's $15 on top of the debt that they owe you or owe anybody else. The $15 is for each individual, a pot of money that's submitted. So they could have up to $45 if all three departments decide to submit bad debt. But it is a really fabulous program, and I think most everybody's using it. There might be some other smaller agencies that aren't using it yet, but if you can, definitely do. A few more tips about Debt Set Off. There was a misnomer that you had to take the debt out after 10 years, and then somebody said after 3 years, and none of that is true. You can leave the debt in the Debt Set Off program for indefinitely until it's paid or until you retire or whatever. It can stay in there. You don't want to remove it from the patient's ledger. You just want to move it over to the debt set-off guarantor. So it takes it out of your actual active outstanding accounts receivable. Okay. Makes it look bad. We don't want to do that. And one last tip about this, just the difference between debt set-off and bad debt write-off. With the debt set-off, you do notify the patient. Bad debt, you never tell them you wrote it off. One you leave on your ledger, the other one is removed from the ledger completely. The debt set-off has to be 90 days old, and bad debt write-off is aged according to whatever your agency policy states, and both require written policy on how you process set-off and bad debt write-off. So I think I've said enough about bad debt write-off and set clearinghouse. So I am going to now turn it over to Brooke Johnson. Brooke, sorry about that, Brooke. I forgot your last name. No, Brooke Johnson. She is going to take you through billing efficiency tips and tricks.
Hey,
oh,
Kathy,
you, Laura.
It looks like Brooke has gotten off.
I don't know where she went. Thank you, Laura. I will mention one more thing about the debt clearinghouse. We do not send any confidential clients to the debt set-off clearinghouse. That's a ruling that we made, and Title 10 supported that, and Women's Health Branch. So we don't send any confidential clients. So I don't know where she got to. Brooke, where are you? This is her section. I hope she's okay.
Remind everyone while we're waiting on Brooks, if you have any questions at any time, just put it in the chat and I will let Kathy or Brooks know. And I do apologize that I wasn't in here before the session begins. And also, if you haven't done so already, can you put your name and the health department or organization that you're represented in the chat?
Let me see if I can find her. Don't think she fell out of her chair, but I don't know where she went. I hope she's all right. Oh, heavens for Betsy. She lost her internet connection. Okay. She's working on it. All righty. Let me do something. Maybe we will just, okay. I think we will skip forward. Hang on one second. I'll go forward to coding and billing the basics, and then when she comes back in, we'll tag her on to the end. We'll make her go last since she fell off the grid, right? Okay, take your time, Brooke. I am switching it up. All right, now that means I have to, don't look at the screen. I got to go through a whole bunch of slides and I don't want to make you dizzy. Okay, here we are. Coding and billing the basics. So these are critical elements, coding and billing, critical elements that you need to provide on the encounter in order to avoid denials and be paid at the appropriate rate in a timely fashion. Okay, so these are a couple of different sections. Okay, CPT and ICD, what are they? Well, your CPT code is what you do, and your ICD code is why you did it. So we've gone through several iterations over the last number of years of CPT and ICD, but we are currently at CPT, I think we're just CPT period, I don't know. Yeah, CPT 2020 and ICD 10. So that has moved forward quite a bit since I started doing this a long time ago. But anyway, if you haven't purchased your new books, make sure you get them. They're out there already. So please make sure you get 2021. And I'll tell you why in a little bit. So if you don't have the correct pairing, as you may know, of CPT and ICD, then they're going to toss out your claim. Doesn't matter who it is. So let's take Medicaid, for example. If you have a client come in and they have a, let me think, they have a well child check, and I know this probably can happen, but let's see, they have a well child check and a well child diagnosis, and then they also have a diagnosis that's something to do with prenatal care, and they're not pregnant, we hope. So something's going to get kicked out. If you don't have the justification behind what the ICD-9 is using a CPT, they're going to kick it out. That may not have been a great example, because unfortunately we do have children that become pregnant early on. But I think you get the gist. Is somebody getting ready to say something?
Yes, Kathy, we had a question back on revenues. Can we go ahead and answer that?
Absolutely.
Okay. It says, in regards to collection, have there been any guidance on if health departments should send collection letters during the public health state of emergency?
Well, we've been asked that question several times, and there hasn't been any specific guidance, but our guidance basically is we're trying to think on the side of being more cautious and not wanting to add more stress to people because they owe you a bill. It doesn't mean forgive the debt, but you may want to back off. And when you're saying send to collections, Danielle, can you expand on that a little bit? Do you actually use collection, or are you talking about debt set off? Maybe she can be a little more specific. Most agencies don't use collection agencies as a traditional collection agency. I know a couple who do, but I'm not quite sure. Are you asking her that?
Yeah. Well, okay. She has to type it in the chat. Mm-hmm. And we can't tell if somebody typing or not. I say if
I just asked her that question to see if she's
okay.
If she can respond before we move forward. I'm sorry. If she comes, okay. Sends a collection letter for those we've identified with balances every 90 days. They attempt to make an arrangement with them prior to sending debt set off. Okay. Yeah, that's your standard practice. I mean, that's debt set off. It's not like you're sending them to a regular collection agency or sending a collection agency after them. If that's your standard procedure and you have a policy that states that, I don't necessarily see any issue with that. The client does have the opportunity, based on the content of the letter, to make an appeal or to come back and say, look, my situation has been very difficult due to COVID. Would you please make some sort of, consideration? That's always their opportunity to do that. And if not, you can just send it. Okay, great. Thank you. Thanks for bringing that to my attention. You're welcome, Danielle. Okay, so anyway, back to CPT, ICD. So the biggest thing about CPT and ICD is making sure that you've got the right match, that it's the correct match, that your providers are putting in the right information as far as the diagnosis codes, and that they are accounting for all of the CPT codes, procedure codes, that they, maybe that's what people aren't in. Andrea, do you see what Laura just said?
And that's what's listed is tomorrow's session, and that's why I went in there. However, can you send out emails to whoever you were talking about and tell them if they, in the search bar, if they type in a guide to successful coding and billing, it will come up.
Thanks, Laura. I wondered where everybody was. I really did expect more people to be on this presentation. Well, at least you're recording it, so they'll get all the faux pas and everything else. It's all fun. All good, all good. We're human. All right, so we're going to move on and talk about new patient versus established patient. For some reason, this is one place in coding that everybody gets tripped up on. What's a new patient? What's an established patient? So we're going to make it really clear that what's the difference between the two, okay? If a patient has been seen for a billable service that includes a history and physical within the health department within a 3-year time from when they present, they are established. If they have not, they are new, okay? Now, let me say that again. They've been in the health department within 3 years for a billable service that includes a history and physical. Those are the key components that would make them established. All right. So we put it out here in both of these bullet boxes, and hopefully it'll be clear. So you can see there, it gives you specific codes about what, you know, if they've been in for certain services, it gives you actual physical and evaluation and management codes there. But the key is 3 years, history and physical, billed. All right. So hopefully that will help clarify that for everyone. Okay. The encounter form. We know that many health departments no longer use a paper encounter. And we are sad about that because it really does help your consultants when we come to do a monitoring or some kind of chart review. It helps us to see what was done, and it's a great checks and balance to make sure that you've got everything that you should and you don't have something billed that you shouldn't have billed. Okay, so we recognize that most of you have gone to paperless. It's not required for you to have a paper encounter, but if you do, I'll just stick my nose in here and say you have to keep it for 6 years based on retention record requirements. But we really just want to make sure that you're putting in and getting credit for the services that you actually provided. And it's your way to be able to bill properly. Modifiers. Who loves modifiers? Yay! Modifiers are good, actually. Modifiers are very good. If they're reported correctly, they indicate that a service or procedure has been performed, has been altered by some specific circumstance, but not changed in its definition or code. They're important because they allow us for more accurate coding, billing, and reimbursement. And we have a number of specific modifiers that we use, and we'll get to that in just a second. How do you know which one to use? Well, your CPT coding book has sections on modifiers. On the inside cover and back cover are usually a couple of flaps. And if you open those flaps, they've got the modifiers listed there, a brief identification of modifiers. There's also a section in the back of the book that is one of the appendices that is for modifiers. So you've got a couple places there. We also include them, so we being LTAT, include them in our coding and billing guidance document, the ones that you would typically use. We have a section on modifiers, so you can always go there to look for the appropriate modifiers, or you can call your administrative or nurse consultant and ask them if they can assist you if you've got a question about it. So, but go to those other resources first. Learn how to use those tools if you don't know how to use those tools, because the more proficient you become at it, the easier it becomes, and the more familiar with the modifiers you become. So it works pretty well. But we're always here for you if you need us. So we have some Medicaid specific modifiers that all of you in public health should know and love by now, I have no doubt. FP is what we need to identify family planning services. Client comes in for family planning services, you have to have that FP modifier on there to indicate that it was a family planning related service. I'm going to jump down to EP for a second. EP would be typically our child health. It stands for EPSTD abbreviated, which is early and periodic health screening. But it's what we continue to use for child health. So that's a very important one to have. The UD modifier. If you are billing 340B drugs or devices, you have to have the UD modifier and the NDC code and the acquisition cost. Those three pieces you've got to have, otherwise you're going to get it kicked out. Welcome to those of you who are coming in a little bit later. We're sorry there was a mix-up with the schedule. So you've got to have those three things. If we have said nothing else over the last year and a half, make sure you know that. Don't bill your regular fee to Medicaid for your 340B drugs and devices. Acquisition cost only, okay? And remember that now that we have all these different products and services, some of them, they all have different NDC codes. So we can't just say, oh, this is a J1050 and go for it. No, you got to have J1050, UD, and the NDC number that's appropriate, and that's usually on the packaging of the drug. Okay. I think most of you know that by now, but it's always good to reinforce. So SL and OB modifiers were created predominantly so that when the individuals that do the cost study reporting, they can go in and they can see that these particular codes have no dollar amount affiliated with them, and they're going to automatically pull those out and not have to look at them for the cost report, because the cost report is only looking at services that were paid, right? So we created the SL modifier to use for local health departments when you use state-supplied vaccine. When you bill Medicaid for a state-supplied vaccine for a Medicaid-eligible client, you're going to be able to bill the administration cost and then report the actual vaccine that you are giving, but the vaccine has to have an SL modifier because you cannot charge for it if it is a state-supplied vaccine. Okay, and I'm not getting into all the ins and outs of state-supplied, private purchased, and all that goody stuff. That's another whole ball of wax. But this is just telling you SL, state supplied, no charge. Okay. OB, reportable maternity visit, was created so that when you are package billing a maternal health client services, you still want to get credit for all of those services that constituted the global or package code, right? Whether it be 3 to 6 or 7 and above, you want to make sure that you count every one of those services. It could be a 99213, it could be a 99212, it could be a more complicated 215, but you want to get credit for it. However, you can't bill all of those services along with the global package code. So you only have to bill the package code, but report all of those other services that you are not going to be paid for. Okay. Again, that's why we want to have an OB modifier on there, but we definitely want you to report those services so that for our HSC statistical purposes, we can see that you've done all that work. All right. And those are the things that those statistics often determine how much money we get from the federal government. So if you're not reporting services that you're providing just because they don't have a dollar amount associated with them, you may want to look at that practice and switch it up a little bit. Okay, that's just an aside about that, but it's extremely important that you definitely report those services. So another modifier that we use is the TJ modifier. Now, that is specific to North Carolina Health Choice, okay? Not health check as in EPSDT, but health choice. Heaven only knows why they chose Health Choice HC when they decided to develop this insurance plan, but they did. So Health Choice has a TJ modifier, okay? And you have to use that modifier for specific services for Health Choice clients. However, you do not use it when a Health Choice individual is receiving family planning services. We had a big mess. It went for years where health departments were doing what they were told to do, and they were only getting paid $90 for the family planning side of the visit instead of what they should have been getting paid for. It took years to finally figure this out. So the easy fix finally was just don't use the TJ, just FP, no TJ, okay? So it's important that somebody in your agency knows all these rules, because if they don't, then you're going to get a lot of denied claims or incorrectly paid claims. It can be a big mess. You want to make sure that you've got all of that information, okay? There is, as I said earlier, more coding and billing information on the within your CPT, ICD, and HCPCS code. Sorry, lost my train of thought momentarily. The code books have a lot of information there. The local health department website, we provide you with a tremendous amount of coding and billing guidance. There's the guidance document. There are all of the Q&As out there. The nursing side has a lot of good information about coding and billing, and auditing for coding and billing, documentation, correct documentation. All those pieces of information are out there. And of course, the AMA is like the end all be all. That's where we get all our information from, between the AMA and then Medicaid, and it all kind of trickles downhill, and then we get it to you. So it's all out there if you just go and take a look for it. So remember I said earlier I was going to talk about why you needed to have your updated code books? Well, this is why. So, and I hope you can see this okay. It's showing up pretty big on my screen, so just want to make sure. There are, as I hope you have already heard, going to be some pretty significant changes in E&M billing in 2021. As a matter of fact, starting January 1, 2021. These all go into play. And I know that's the last thing we need to hear on top of COVID and telemedicine and all those goodies, right? But there are going to be some significant changes. These are resources that you can look at and get a wealth of information to get you going. Don't wait, okay? If your agency hasn't touched on what's going to happen in 2021 with E&M, then please make sure that somebody gets this information and get started on what to do, how to do it, when to do it. We have had very few health departments inquire about training. And we recommend the first bullet, the AMA, for any provider or physician training regarding the evaluation and management changes that are coming forward. There is a series of 9 or 10 different modules that they can look at that will give them an in-depth look and training on what's going to happen. Very good for them on their level. It'll be perfect. The other 3, 2 of them are AAPC, which is American Academy of Certified Professional Coders, an association that I belong to that has provided us with some really good information. Both of these AAPC trainings are out there available. You can click on the links and you can take a look at those. And then lastly is our local health department website, which has information currently. We will continue to put information out there. It will come as we have it available to us. We're in the process of developing that content, but please keep your eyes out for more information on our website about the evaluation management changes that are coming forward in 2021. Okay? And that's all I'm going to say about that. Have we had any other questions come in? No, I don't see any. Okay. Brooke's still not back with us, so I'm going to go forward and continue with what
I'm
I've
here.
got going
I'm
on.
here.
Okay.
I'm here.
You're here. Okay. So I'm going to go ahead and finish this section on
Okay.
COVID and telehealth, and then we're going to go back to you, if that's okay.
I do apologize. My Wi-Fi hit the dust, so I had to call IT. So thank y'all.
Oh gosh. Okay. Yeah. Right in the middle of things. Always. Isn't that the way it goes?
It is.
Kathy,
Good. Yes, ma'am.
Will you make these slides available to our attendees?
Sure. Yeah. Will you be able to send those out? I can send them to
Yes,
you.
ma'am. If you send them to me, Kim said next week she will upload them to the FAMI section.
Excellent. That would be perfect. Yep. Be happy to do that. We'll do it for you. Great. Thank you, Danielle. Yep. Thanks, everybody. Okay.
Laura, that's funny. He is actually still asleep.
That was good, Laura. Okay. So that was a fun little break. Let's talk about the elephant in the room. COVID-19 and telehealth billing. Okay. I know this has been at the forefront of everything that we in our shop, LTA TV, have done pretty much for the last 6, 7, 8 months. We have tried to stay ahead of the curve for you so that we would have all the information to be able to share it with you and give you expert information. And I think we've done a pretty good job of that. But one thing we do want to remind you of is what we've got on the slide. Remember that all guidance related to COVID is temporary. This guidance will be discontinued at some point in time once the public emergency is declared over, okay? At that point, we're going to move over and transition to telehealth, which some of you were doing before, and that's fabulous. So this is not a new ball game for you. But we're going to continue. Telehealth, telemedicine is going to stay a constant, we feel very strongly about that. And I think there's a lot of individuals out in the world that agree, would say that that is true. So we're going to continue to learn everything we can, but we want to give you as much information about COVID telehealth and telehealth billing as we can. So we have, let me quickly look ahead here, hang on. Yes, we do. Okay. I'm going to show you closer to the end of the presentation where you can find information about COVID billing and COVID-19, as well as on the nursing side of things, policy, procedure, and some templates that the nurses have put together from our shop that we have included on our website. So we're going to go look at that a little bit later. But for right now, I want to talk telemedicine, telepsychiatry. All right. We know that Medicaid has put out special bulletins ad nauseum. So I think we're up to, I don't even know, I've lost count. But anyway, we know that there's special bulletins coming out on a regular basis that relate to COVID-19, billing, services, additional funding, everything that you can possibly imagine. And we have shared all that with you guys. We have prepared our COVID-19 billing quick guide, which we have published on numerous occasions, and it gets updated every time. New information gets out and comes out. The last one was February the 25th, I believe, that we did that. But I want to touch today on a couple of key bulletins and some key information that you need to know now and going forward. And it's specifically about some of the dates that have been designated and shared so far. Okay. So Medicaid bulletin number, special bulletin number 34 is probably your best bulletin for looking at clinical information. It's got the summary of all of the different codes that you can use, services codes, eligible providers, definitions. It's got everything out there for you, okay? In addition to that bulletin, which is key, and all the other ones that came in between, bulletin number 134 came out, I think, about a week ago. And it says, it clarified the COVID-19 temporary rate increases and clinic policy changes, okay? Several items of note in that bulletin include the Federal Public Health Emergency Declaration. So in Bulletin 119, it correctly noted that the federal public health emergency was extended on July 25th for up to 90 days. The current expiration date for that is actually October 23rd, not October 25th, which was a misprint somewhere along the line. However, given the state that we are in, that COVID is not even going anywhere away, unfortunately, the federal government may continue to extend the public health emergency beyond that date at its discretion, okay? So that means to you, keep your eyes open. Look for all the information that our shop sends you. Look out there on the Medicaid site for your own self to keep tabs with what the date ranges are and when this is all going to come to a stop. Because what that means is that you're going to have to switch gears and you're going to go from COVID to telemedicine. And it's going to be potentially a different ballgame, okay? However, Bulletin 134 also says that Medicaid has determined that it is necessary and feasible to continue the temporary enhanced rates related to COVID-19 through the expiration of the public health emergency, currently October 23rd. If the federal government extends the federal public health emergency or takes other action, North Carolina Medicaid will assess both needs and available funding. So right now, everything is due to stop October 23rd. But we know, based on just kind of where we are, I would say we know with a pretty surely that that will probably be extended. Okay. But again, you need to look out for the bulletins and look out for all this information that our shop is sending to you. Okay. The third piece of this is the temporary clinical coverage policies. Bulletin 119 stated that those would be extended through December 31st. Okay. Some of the policy modifications require an extension of the health emergency declaration to continue beyond October 23rd. Told you there was a lot of dates in here. However, many of the clinical coverage policy provisions, such as telehealth provisions enacted to support COVID response, can continue past the public health emergency and, good news, are in the process of becoming permanent policy. North Carolina Medicaid is seeking federal authority where appropriate. And yes, I did read that verbatim. That was verbatim out of what the Special Bulletin 134 said. So, what did I say? Okay, right now, the federal public health emergency runs through October 23rd. It is quite likely that that will be extended. Through what date? We don't really know, okay? Same thing with the temporary rate increases. Public health has been extremely fortunate. We have received a 45% increase in what we are reimbursed from Medicaid during the COVID emergency. That is significant. We don't know if that's going to stay. We don't know if that will change. We don't think, now don't, I'm saying don't think, I've got witnesses. I'm not saying they will, but we don't think they're going to take us all the way back to where we were prior to COVID. There's going to be some changes. So again, keep out for that. And then the last thing is the clinical coverage policies. The majority of those clinical coverage policies that were set forth regarding telemedicine for COVID response will continue, and Medicaid's in the process of making them permanent policies. Okay? All good stuff. All right, good. So let's see. One more thing here about telemedicine. Everybody's favorite topic these days. How many emails and phone calls have we gotten about that CR modifier? We really don't like the CR modifier.
A million.
And we know that it has caused all of you a lot of stress. So we are hoping that this information, which we got directly from Medicaid, will clarify for you. We've already sent this out to you all on September the 4th. We sent this information out to all of our health departments and our partners. We hope that that word has spread so that everybody is clear about when and when not to use the CR modifier. So, slide says, CR modifier is to be used with telemedicine or virtual patient communication that was COVID related, okay? And then we clarify COVID related telemedicine and VPC is interpreted as providing services by telemedicine and virtual patient communication due to COVID and the state of emergency. For example, seeing a patient by telemedicine or VPC rather than having the patient come into the clinic, all right? It does not necessarily or exclusively mean that they have a COVID symptom or diagnosis, okay? That's when you use the CR modifier. If you have to use telemedicine or VPC in order to see your client to prevent them from being exposed and coming into your clinics, that's when you use it, okay? So hopefully that is pretty clear. We also recommend that you carefully review the Medicaid telehealth billing code summary, and we've provided the link there for you as well. But that is the word that we have received from Medicaid. So I have a few more slides I want to talk about, but I am going to let Brooke, I'm going to go back to her section.
Can y'all hear me? Can y'all hear me good?
Yeah, you're really loud.
Okay, let's see if I can. I'm really loud anyway. Y'all all know this.
Don't look at the screen. I'm scrolling again. Let's see, get back to her section. Okay. All right, billing efficiency tips and tricks. I will move your slides for you. So,
okay.
Because you can't do that right now, I don't think. Right? Can you?
No, I can't. No.
Okay.
So I want to thank everybody for being here and having us today. My name is Brooke Johnson. I'm the Eastern Region Administrative and Financial Consultant. So I look forward to talking to you guys today, and I'm glad that we actually can be in a chat room and actually y'all can see us. I hate we can't all see you guys, but it's really awesome to be connected because I think we've missed some of that through COVID. So I feel like it's a little blessing that we are all able to kind of connect here. I want to thank Kathy for everything she did because I had a horrible connection and my internet totally went out. So I'm going to be talking about the billing efficiency tips and tricks. So you can find some of this, you can find in the Code and Billing Guide document and on our website listed above for the latest Code and Billing Guide document. And as Kathy had mentioned earlier, the last Code and Billing Guide document that was done, I think was February 25th, was when we updated it. And we had a lot of updates from the 340B. We sent out updates for the programs to update to us, and that has been completed. We do have an updated version 16, and it is on the desk of our supervisors right now to see how we are going to present that to the health departments. But you will be looking for that very soon because that should be in the next couple of weeks. So the Code and Billing Guide and document, I hope all of y'all are using the Code and Billing Guide and document and y'all are going through it. You can see that we have changes. We make every attempt that we can to make it correct. But if you do have a program, question, please contact the program consultants. It's really important to say that because that's what they're there for. You can always contact us. That's awesome. But sometimes even we are going to guide you to them. And just make sure that that's what it's developed for, is the program consultants and us all working together to make sure this is the best document it can be. So what are you going to find in the Coding and Billing Guide document? You're going to find your slide and fee scale, how to do that, your CPT codes, your ICD-10s, your guidelines for the programs are going to be in there, your clinical coverage policy, and there's a whole lot more. There's even scenarios in there for some billing, some of your labs, and each section is sectioned off, so it's really easy to find. So if you have not checked that out, please go to our website and definitely check out the Coding and Billing Guide document. Because you can also hit the find button, and if you're looking for 340B or some keyword, it'll take you right to those sections that it's in. So are you in network or credentialed with third-party insurance? I know we've asked you this 100 times, but it's important to try to be credentialed with the insurance companies. The slide examples, why would you need to be credentialed with insurance companies? And is there someone in your health department that is responsible for credentialing these providers, getting the providers credentialed, and then moving to the insurance and credentialing them with Blue Cross Blue Shield, Medicare, whomever you choose to get, credentialed with? So there are key points that you need to see. There's also a website on here that I want to bring your attention to, and I'm sure that some of you are doing that already, is the CAQH. Make sure you're putting your providers in that system, because that's a really good system to pull that information from and be able to pull it over to the insurance and stuff. So electronic billing. So we're all doing that to make sure that you're receiving all your revenue. We like to do that electronic billing. And you want to check your edit reports. So when we send the billing off, you want to make sure that your claims passed through the clearinghouse. And if they didn't pass through the clearinghouse, that means they got rejected for some reason. You need to be working that rejection bucket or those rejections. If you had edits that didn't go through, like say the name was wrong or the address or whatever, you need to work those too, because they're going to fall out of that clearinghouse. And you need to make sure your claims were accepted. And then you need to make sure that you rebill anything that fell out of that pile. And just have a system going so you can make sure that your rejections don't pile up. And if you have a claim that's really difficult, because sometimes we have claims that we just cannot get Medicaid to pay. Sometimes we can't get Blue Cross Blue Shield to pay them. Remember that you can also do the electronic billing directly through NC Tracks too. You can go into NC Tracks and key that claim, and then you can go back and see that claim. You can follow it right through NC Tracks. You can see if it went through. You can see if it paid or denied, and you can see what it denied for if it did deny. So just know that you can also bill directly to some insurances too, like Blue Cross Blue Shield. You've got Blue E. Any of the health departments out there are working with Blue E, you can key directly into Blue E just like you can NC Tracks. How are you following up on your billing? Is someone doing that? Is it a collaboration of people doing that? You need to make sure that you're working your denials. You do not want your denials to start piling up where you are unable to work those denials because it's just too many now. And in your policy, your fees policy, you should have, that row. What is your how are you addressing the denied claims? How are you working the denied claims, and what are you doing about them? And you can find a sample fees policy on our website. So Kathy had mentioned the age accounts report. The age account report is one of the most important reports to run for your denied claims or any claims to make sure that everything that you're sending out, you're getting something back. You run your reports on a regular basis. And this is important because most companies are only 90 days. So you want to make sure you've hit that 90-day window so you're getting paid for what you do. You research your claims showing the 31
Sorry.
to 60. Yes, go ahead. 61 to 90 days. And Kathy had mentioned that in an earlier slide, so hopefully you will see that there won't be any older ones, but if there is, you want to hit those and get those cleaned up. You do not want aged accounts on your accounts report. Are there a number of claims that were sent on the same date? Is there a pattern? Do you see a pattern going on where maybe you didn't get paid for the date that you sent and it's all got the same date on it? That's a pattern. That is something that you need to follow up on. What if you sent your claims in and you know that you sent your claims in, you've got the RA, you know you got paid, but you can't find the money on your screen or your electronic bill? You know that there's something wrong there. That's a red flag. You need to research that. Are there denied claims that have been worked? Make sure someone's going back and checking to make sure those denied claims have been worked. I thought it was really important to read those bulletins just because it has everything to do with the revenue coming in your health department and what you send out. So how are you going to increase your revenue with in-house audits? Everyone should be doing audits in your health department, and you should be doing that with your clinical staff. So you need to make sure your in-house audits include your clinical staff and your billing staff. This ensures the agency is coding, billing, everything correctly, because the clinical side is going to catch things that the billing side may not. So it's really important that you do this in pairs, like we work in pairs, and that way y'all can catch each other's stuff and you will know what is correct and what is not with the billing. So who forms the in-house audit? How should we do this? Who should be on the committee? So you should first start a committee and say, we need to have an audit. Who's going to be on here? Providers, nurses, billing, management support supervisors, if appropriate, your care management. Pair your clinical and your billing management support staff in that committee. You pair them to look at the accounts or the claims together. And because that clinical staff is going to look at the CPT, ICD-9s, and they're going to make sure everything works together. Your billing staff is going to make sure that they're looking at things like, was it signed? Was the sliding fee scale applied? Was it billed correctly? Was it billed to the right person? Was the demographics done? That's why it's so important to make sure you pair them together, because they're both looking for the same and different things because they do different jobs. Who should not be on there? The non-clinical professionals, such as the health educator and WIC, they shouldn't be on there, okay? Unless they are participating in the clinic stuff. What are some of the questions you should ask when you're auditing? To me, this slide here are some of the key questions you should ask when you are auditing for the billing and coding. These questions will help ensure the agency is billing correctly and errors are being documented for improvement, because that's the whole purpose of the audit, is to make sure that if you are doing something wrong, we fix it, we improve on it, and we don't let it happen again. You may note that these are the items that the administrative and the financial consultants, us, review during our administrative monitoring. And that tool is actually on our website. So you are able to go to our website, pull our tools, see what we look for, and you can gauge some of your audit through that. Because we ask questions like, was the sliding fee, applied? Was it applied correctly? And we, was the copay taken? Was the copay taken correctly? Was it posted correctly? Did we post it to the correct account? Stuff like that. So it may be helpful to include registration and intake staff in addition to your billing and management support supervisors. To give, because once you've reviewed all your records and your data and you've compiled an improvement, report, basically, this is what we've got, this is what we did, this is our errors, and this is what we're going to do to correct it. You want to give that plan to everybody so everybody's on the same page and everybody's working towards the same goal. And I think it's real important that they get this feedback and they look at these reports in the committee and talk about it, because you can only improve every time. The purpose of the in-house audit is, like I said, to catch all the errors before they can get too big. It will also improve your billing, your revenue, and your coding. This is a great way to train staff. You've got that report in front of you. You know that maybe it's a problem. This is what our problem is. It continues to happen. Let's have a meeting. Let's get everybody together and let's talk about what this problem is so we can make sure that we correct it and it will not happen in the future. I think it's really important that we do that. Audits should be performed every quarter. If possible. I know that you guys are busy, but this is only going to increase your revenue and help you guys with what you've got.
Okay. Look away, look away. Oh, wait a minute. I jumped right past where I was going. Okay. I don't see any questions in the chat box right now. So we're going to go ahead and move forward to wrap up our presentation. There is a wealth of information on the DPH for local health departments webpage. Okay. And if you have checked it out recently, you'll find that it looks a tremendous amount different than it used to. It is very different. And I'm really excited about that. And I hope that it makes it easier for all of you who use our webpage to find what you are looking for. So just a few things that I wanted to bring to your attention, as I had mentioned earlier. We've got icons, icon boxes that try to give you a sense of what you're going to find underneath the particular header. So one of the ones that I want to share is the Administrative and Financial Support Unit. In case you hadn't figured it out by now, we now have a unit. We are administrative and financial consultants, public health, administrative and financial consultant. We have our own unit under the LTATB heading, much like the PHNPDU. That's the nursing side of things. So there are currently several units plus some ancillary additional critical staff that are underneath LTATB. But the administrative and financial section, you'll find all your tools for administrative monitoring, budget prep, consolidated agreement, forms and tools. Very important piece of information. Don't recreate the wheel. Go out there and use what we've shared with you. We put it out there for a reason, and we've gotten permission to we've either developed it or we've gotten permission to use it. So all of our newsletters, our news and notes that we had started doing and are only on pause because of COVID, those are all out there. The policy and procedures that we have shared with you, plus our sample fee and eligibility policy is there, and any training that we have posted for you out there. So that's a good bit of information. And then on our companion side, the nursing side, you will find lots of good information if you are working with the nurses. But the one thing I wanted to specifically bring to your attention are the coding and billing review tools. These are the clinical tools that they use, but important for you if you're doing audits. You want to make sure that you've got, or record reviews, you want to do both the billing, coding, and the clinical side that the nurses will work with you to perform. Documentation guidelines, which are going to be very important, especially coming into 2021 with the E&M changes, because they're going to lean on some of that documentation a little more heavily than they have in the past. Some documentation, training, and licensing boards are there. So lots of good information there. And if you hadn't caught it, our web address is up here at the top of this slide. And then one more slide, we've got our coding and billing resources, which is basically what you are used to seeing before. It has all the coding and billing guidance document information out there, all the trainings that we've provided related to the coding and billing guidance document. Right now, it houses all of our COVID telemedicine billing. All our COVID resources are out there under the coding and billing resources tab. And under general information, is kind of like the other things that you would typically find. But the one thing I want to bring to your attention here is telemedicine. So remember I said once COVID is starting to wind up, we're going to start developing more on the telemedicine side, straight telemedicine. And we're going to leave all that COVID stuff behind. Hopefully that'll be sooner rather than later. But that's where you're going to go to find straight telemedicine information. You no longer will use the COVID information specifically, but you're going to go here under general information and pull the telemedicine tab and look under there. So, questions at this point? We are done with the presentation. Any questions you might have, I'm going to roll on and just let you see our resources that we used for today's presentation. Thank you so much for the
Thank you.
Lovely comments. And then this is our map, current map, I shall say. So for those of you who are on, and for those of you who know me or have heard my name across the state, that top box is going to change a little bit at the end of this month, because I am finally, after over 20 years in public health and a lot of years working doing other things, I'm retiring. So it's bittersweet. I will miss you all tremendously, and it's been a great pleasure. And I'm going to tear up. Oh, that's not professional at all. It's been my pleasure to work with everybody in the FAMI section, and of course all our NCPHA partners and colleagues. So thank you.
You will be missed so much.
I mean, you definitely will, because when I sent you that email about the management support meeting, you said, I won't be here no more.
Surprise!
But you will be missed, Kathy. We do appreciate everything that you are willing to step up for the FAMI section. Whenever I call you for management support or any of that, you are willing to be that go-to person. I know Brooke is my consultant, but
yes,
you always step in.
Thank you, everybody, for your notes of congratulations. I appreciate it very much. It's kind of it's a very bittersweet moment, as I said to one of my colleagues earlier today. It's exciting, but it's scary, but it's time. So let the new kids take it on.
You will.
And y'all just remember that to contact your consultant if you need anything. We're still here, and we'll be glad to help you in any way.
Well,
thank you, everybody.
I appreciate you, Kathy and Brooke. And I will get the information from Kathy or Brooks to put and make sure I send it to Kim to put on our page.
Yes, I'm going to send it to you as soon as we get off of this presentation.
Yes.
I'll go ahead and get it to you so I don't forget it.
All right. Well, thank you.
Thank you, Andrea.
Thank you all so much.
Make everyone aware, if that you are a part of the family section, we do have our business meeting via Zoom. I sent out an email with that Zoom link tomorrow morning at 8 o'clock. I'm going to put my email in the chat. If you have any questions or need me for anything, please feel free to contact me. I will be the moderator for the remaining of the conference.
Great. Thanks a bunch,
Awesome.
everybody. Have a good afternoon. Bye now.
Thank y'all. Have a great day.
See ya.
Bye-bye.